Could I ask Dr. Kristina Sirakova, did I pronounce it right? And we'll start the intracranial interventions. And you're going to talk about progressive volume reduction following flow diversion treatment of giant and symptomatic cerebral aneurysms. Could you just...
So I would like to ask Professor Sirakov to come as a panelist, Omar Abu Ferres, and Naji Kozer.
Welcome, you can start because I think we are late enough.
Okay, greetings everybody. My name is Kristina Sirakova and I'm delighted to have the opportunity to be invited to talk about very unique phenomenon commonly associated with endovascular treatment of giant cerebral aneurysm, or in other words, the volumetric reduction of the aneurysmal sac. So giant aneurysms are notorious for their size, that by definition must be or exceed 25 millimeters in diameter. Given the larger size, they are considered an occupational process that usually is embedded in the brain parenchyma, causing compression and or edema. So their morphology usually follows a distinct pattern of broader neck, incorporated side branches, and or sometimes being present with intrasaccular thrombosis. Statistically speaking, the internal carotid artery localization is the most common observed, especially the extradural part of the artery. They are still considered as a threat to the cerebrum due to intense compression symptoms, often associated with local dysfunction or cranial nerve palsy. All these factors are considered limiting factors for the conventional surgical approaches. The border neck usually exceeds 7 to 10 millimeters in diameter, often necessitate the constructional microsurgical approach. The technical improvement that we have witnessed in the endovascular field over the course of the last decade have made this approach considerably appropriate to deal with the challenges of the giant cerebral aneurysms. For the sake of the presentation, we have conducted a retrospective analysis that we have identified 51 patients with symptomatic giant aneurysms that underwent endovascular treatment with flow diverter stent. Aneurysmal and demographic characteristics have demonstrated that these aneurysms are commonly seen among the female patient. The regular aneurysmal configuration is with neck approximately 8 millimeter, 26 millimeter in diameter, and extradural localization of the ACA. We have identified only the radiological and clinically symptomatic giant aneurysm, and the most common clinical manifestation in the cohort was third cranial nerve palsy, followed by chiasmal and second cranial nerve compression. It's always rewarding and interesting to see the aneurysm shrink and the patient symptoms improve during follow-up. You can observe by yourself the clinical symptom regression. And now, please allow me to present you several cases. I have selected a few aneurysms that demonstrate significant shrinkage after the treatment and over the course of minimum 3 years follow-up. This is a pre-treatment MRI in the patient with symptomatic left ICA cavernous aneurysm. The patient was present with prominent third cranial nerve palsy. You can see the angiographic effect of the treatment and the reconstruction of the parent artery of the left ACA. Over the course of the follow-up, the aneurysm shrunk to the point of dropping over 1/3 of its initial volume. You can clearly see the signal shifting inside the sac, demonstrating progressive thrombosis as well as reduction of the size. Another clinical apparent giant aneurysm. Despite the extradural localization of the ACA, the giant size of the aneurysm was the direct cause of the left cavernous sinus syndrome in this patient. The endovascular treatment resulted in the complete exclusion of the aneurysm over, of course, 6 months. Nearly 2/3 of the aneurysms were gone, and on the last MRI conducted 3 years after the treatment. The significant volume loss has alleviated all the clinical deficits of the patient. The third case is right ACA aneurysm treated by endovascular means via flow diverter stent. So you can see the dynamics of volume loss that we have confirmed to slowly regress over the course of 6, 12, and 22 months, a dogma that we have questioned over the years. Some aneurysms are considered a little more dangerous, especially those with giant size and located across the posterior location and due to severe compression of the brain stem. The flow modulation of the stent initiates a progressive but steady thrombosis of the aneurysmal sac for the first 6 months. And similarly to the healing of an open wound, the thrombotic materials transforms and loses mass. Another case example of giant cerebral aneurysm treated with flow diverter stent and loose coiling. The pre-treatment MRI demonstrates bilateral aneurysms with the larger and clinically apparent one located on the left ACA. Covering of the neck of the aneurysm with stent as well as few coil inside the sac to induce faster thrombosis. So we can see the significant volume loss of the aneurysm over the time. Note the changes of the volumes before and at the point of the last follow-up. Interestingly, in our analysis, we have failed to demonstrate whether localization matters for the volume changes. Considerably, the same changes we have observed in both extradural and intradural aneurysm of the ACA. The angiographic occlusion was confirmed 6 months following the stent. On the other side, the MRI 3 years later makes it extremely hard to guess where the aneurysm has gone. I believe that the word giant does not validate this aneurysm. Enormous and partially thrombosed aneurysm in a patient with a visual deficit. Occlusion of the aneurysm was performed with FD stent. Considering the mass of the aneurysm and the chronic partially thrombosed nature, that was probably over 2-3 decades old. So you can see the progression of the thrombosis over the period of 5 years. The aneurysm demonstrate apparent changes in the signal integrity of the thrombus, with significant volume loss and decompression over the brain parenchyma. Some other aneurysms located above the dural ring, like this para-ophthalmic aneurysm, can completely vanish in period of 2 years. Note the changes inside the sac and the volumetric loss due to traction forces and transformation of the thrombus. Results are great when there is no complication. However, complication will happen and will occur regardless of what we want and what we aim for. Some aneurysm will enlarge or will worsen the edemic changes over the brain parenchyma. This is an example of post-procedural complication. We see aneurysms located into left ACA and aneurysms that was partially thrombosed and partially coiled, and flow diverted. MRI demonstrate extension of the edema changes around the aneurysm and volumetric growth of the aneurysm despite of the treatment and the medical therapy. Rupture and enlargement. This event is usually in giant aneurysm. When the thrombus formation triggers an inflammatory process that lyses the aneurysmal wall, causing intraparenchymal hematoma, like in this patient, the delayed rupture occurred in 22 postoperative days, causing bilateral blindness. To control these events, an update of medical management is proposed that it's concomitant to the endovascular treatment. The aggressive therapy proposed here aims to reduce the inflammation inside the aneurysm while the thrombus occur. So this is our protocol. And thank you for your attention.
Thank you, Dr. Sirakova. Is there any questions from the room?
I have a question to Dr. Sirakova. Thank you for your wonderful presentation and amazing cases. I saw that in some of the cases you were stenting with a flow diverter and coiling, and in others... Coiling and stenting? Sure. Sure. Okay. So about the decision for delayed rupture, in which cases you choose to put coils in the aneurysm to reduce the risk of delayed rupture, and in other cases you choose not to. Maybe we'll answer, or you?
I will try. So our selection at the beginning was not very clear. So the first years, in my mind, I want to induce faster thrombosis. So I put a foreign body inside the sac, put a flow diverter. In my mind, it was safer the aneurysm to induce faster thrombosis. But of course, we didn't initiate the correct medical treatment at that time. So that's why at the beginning we saw that. Afterwards, I started to not putting coils inside without knowing the real reason for delayed rupture. And lately, I'm completely sure that with my colleagues reached the conclusion the medical treatment, anti-edema treatment, is more crucial to induce not so faster thrombosis, so not so severe inflammatory reaction, and maybe this will reduce the risk of delayed rupture, in my mind. So to put or not to put coils, I don't think maybe we will answer our questions. Maybe Professor Kucet has more experience in that, and maybe share when to put or not to put coils.
We started not to put the coil at the very beginning, where the modern flow diverter period started in 2008. And then we realized that complication. Right now, my protocol is intradural giant aneurysm. If it is coilable, I'm coiling totally, not partially. And then deploying the flow diverter in the same session or delay session. That is my protocol. I agree with the corticosteroid therapy and edema therapy, but eventually it all depends on the partial thrombosed calcified wall aneurysm or not. If there is a partial thrombosed chronic calcified wall images with covered thrombosis in the lumen, it's much more safer not to put the coil. That's why decision should be done. The location, morphology, integrated vessels, thrombosis, calcification, and intradural location.
Some other comments or questions?
Hello. Great presentation, thank you. These kind of aneurysms are the most beautiful results we have. So something which is giant and then it goes away completely, disappears. So yes, but they may also be the worst cases because they may grow with edema and they may rupture, bleeding. So the question is numbers. In intradural cases, giant cases, how often you have a bad result compared to how often you have a good result?
Part of the same team. So I think I think the agenda was we analyzed up to 50-ish cases we did, and we've noted only 2 complications that were related with intradural localization. One was the patient that you saw that went blind because of the delay rupture. Previously, we didn't actually assign any anti-edemic therapy or non-steroidal inflammatory medications to this very patient. Then afterwards, we saw only 1 delay rupture, but I don't think that was a delay rupture because the patient actually experienced SAH symptoms on the 7th day. So that concludes to 2 cases from all the 50 cases.
Growing without rupture?
There was the growing of the, you mean increasement in size? And a few cases, maybe I would say 6 cases. But all those cases resolved simultaneously with the therapy. Yeah, of course.
I just want also to share that our struggle at the beginning with our neurosurgeons was to convince them that this volume and the mass effect which caused the symptomatic for the patient can be resolved by this treatment. It's not necessary to do a bypass, to remove this mass effect by surgical approaches. So that volume loss idea of the presentation was also to convince our colleague neurosurgeons that the symptoms may regress, and most of the time they will.